I'm Fiona Moss. I'm a member of the Strategic Advisory Board for the International Forum on Quality and Safety. And I'm here with David Zideman, Clinical Lead for the Emergency Medical Services for London 2012, Pam Venning, Head of Medical Services for London 2012, Peter van der Vliet, who's a Medical Director of the International Paralympic Committee, and with Laurence Gant, the Clinical Lead for the Polyclinics for London 2012. Thank you all for coming. We've heard, by all accounts, the medical services for London 2012 were successful, and we've heard from you all today about the extraordinary amount of work that went into building up to them and just why they were successful. I'm very keen to explore with you all the legacy not just for the Para and Olympic Games for Rio 2016 and all other big games, but also for the NHS in London, the NHS as a whole, and for healthcare internationally. David, I wonder if you'd like to start from your experience developing the emergency medical services.
Thank you very much. The emergency medical services, we found, worked very closely with the ambulance service, which actually was a national ambulance service for the Olympic Games. Although London Ambulance headed up it was a national ambulance service response. And so there was tremendous legacy, which is ongoing into 2013, 2014 for the future. And that's been a huge advantage and has helped the services. From the medical side, more specifically from the field of play and from the spectator side, I think what we've learnt is that training volunteers and training to a uniform level of performance with uniform equipment was certainly a huge legacy for the future and has been taken forward into a large number of major sports nowadays, and you'll see it in a lot of sports stadia in the future.
So the medical service or the volunteers, say at one of our big football matches now, they'll be trained to to a better and higher standard, and there possibly more of them?
Yeah, absolutely. Probably not more of them, but trained together. And I think the secret was training the team that were actually working on the day to work together. So not turning up 5 minutes before the game starts, but turning up probably an hour to an hour and a half, even earlier, to work as a team with the various people and with the equipment that's available, and sorting out real problems such as extrication from the top of a stadia or how quickly or where you're going to move off the field of play. These were real problems, and dealing with them in real time and not just discussing them or just saying, oh, we'll get round that one. This is a real advantage.
Thank you. Pam, you were talking earlier about sort of because people had to volunteer to be part of the service. I wonder if you just said a little bit about how you selected people for that role.
Yes, the people volunteered through the volunteer portal, and then we had to select them from 18,000 people. We then got down to 10,000. Everybody was interviewed prior to the Games for half an hour. It was a behavioural interview, so we knew that these people were qualified and experienced enough to do the job, and then they were interviewed to see if they would be a good games maker at games time. And there was one question which helped us choose our staff, which was when could they describe when they had gone the extra mile. And it was quite intriguing because a lot of people said, I do that every day in my job, and I'm afraid when I saw that I put them in the no box. And when we found people who had gone the extra mile to help their patients, learning sign language, to work with deaf patients, they went in the yes box. So we were very lucky to have such a pool of people to choose from, and then we were able to choose some really outstanding volunteers. I think the other aspect is that I was very keen, and the team were very keen, to make sure that we were a team. So when we got them for the first time and we met them face to face, that was our premise. We were going to be a team, and we welcomed them into our medical team. And once we explained the situation to them and we said to them, you're the experts, you're bringing your skill to us, we'll give you the framework to work, they just took it, and they will take that back into their place of work, that teamwork, that level playing field, the skill mix, and hopefully it will have a longer term effect.
Well, there's two things you said there that seem to be particularly relevant to the conference we've just come from.
Yeah.
One is the going the extra mile when they can describe learning sign language, for example, rather than what is sometimes called, the doctor's hero, always thinking you've got to do something yourself to actually to get something done, rather than, as we've been hearing over the last 3 days, the importance of changing the system of care to make it work better.
Yes.
How do you think we can get that learning into the health service? I mean, generally, and again, this is an international issue.
I think, as we discussed before this started, I think the hierarchy is the issue here. That everybody can bring something to the table, and that should be respected. And I think there was one quote from a very senior academic GP who said, after the training in the polyclinic with Laurence, she said to me, "Oh, thank you very much." And I said, "Why?" And she said, "You're treating me as an equal. I thought you were going to come and tell me to do some things in a certain way." So I think it's that concept that we are one big team, everybody brings something to the table, and there's the leader of that team is not necessarily the person you think it is, and it's a skill set, and that concept, that idea, stepping back and having a look at how you're going to deliver the services. And we've all worked in the healthcare sector for many, many years, and it was refreshing way to work, refreshing.
Because teamwork is extraordinary. If teamworking was a drug, everybody would have it when they came into hospital.
Yes.
Because we know that actually if you work in a good team, if you're cared for by a team, your outcomes are significantly better. And is there anything from that we can carry across? Because it seems to me you've...
I think the other issue we did, particularly with the Paralympics, was spent very early on working with Peter on did they need any different care to an Olympic athlete? And we spent 2 days in a room together with experts, and we're very lucky in the UK to have expertise. And we came up with that premise that they're athletes first, and also they know what they need. And that was the same for Olympic athletes as well. They know what they need. They know their bodies better than anybody, because they have to look after them and compete at such a high level. So the patient, or the person that you're dealing with, is also the person that needs to be part of that team.
Because again, that's something else we've learned over the last 3 days, and that is patients as partners, not as people to whom things are done, which actually is hugely important.
We had, particularly because of the athletes, we had an athlete committee made up of Olympians and Paralympians who checked everything we were doing as we planned the games, including the medical services, and they would feed into it and say, what we can make it better for that team member, that person in our team.
Peter, the Paralympics were an enormous success, and as David Cameron has pointed out, they really have made people with disabilities visible by their abilities, and it has changed the way in which we view people with disabilities in London and in the UK. Do you think it's had the same impact on how we care for people with disabilities within our health services?
Well, of course, being international, I'm not 100% familiar with what happens on the national level, but clearly, at first hand, they're athletes, and that's where you need to see them. And I tried to bring that message over from the very beginning. The other key deliverable you need to look into is when something works for the Paralympics, it works for the Olympics. When you treat it the other way around, you run into accessibility problems, just to name a logistic one, but you also run into the not to cope for the unknown. Yeah, Paralympic athletes bring very particular issues, and as Pam came to say, they know, and you need to engage them in the whole process. We do exactly the same from our medical committee perspective. I have 2 athletes with medical qualifications on my medical committee who are my daily advisors. That means they speak from their experience as a medic, but also from their experience as an athlete. That information is crucial to me because more than any Olympic athlete, a Paralympic athlete is unique in his performance, but also in his impairment. And they know their body, they know what to do, so you need to make them partner of the whole planning. Locock did an absolutely great thing by bringing these medical advisory groups together, by bringing Paralympic-specific experts to it, but by bringing athletes to the table to find out what is it that they need and what they require. And if that is carried on now in National Health Services, give these individuals with a disability, if you make it larger, if you give them the platform to become a partner in the whole process, you create a win-win situation for every party.
Yeah, I think that, again, something that I took away from your session was that actually if it is good enough for Paralympic athletes, it's good enough for Olympic athletes. Absolutely. If we developed and designed our health service to be good enough for people with disabilities, then actually everything will be fine for everybody else.
Yeah.
And that's
But
really quite a change in headset.
Absolutely, but you can even go in that awareness part, you go wider. If you make things accessible, if you talk about accessibility, if you make it accessible for a wheelchair user, it becomes accessible for the elderly, it becomes accessible for mothers with young kids. So it's much more. You need to watch outside of that box. If you have a fully integrated approach from the very beginning, you just remove all physical and behavioral barriers to work with those individuals.
Okay, thank you, Laurence. The polyclinic was fantastic, and it's I think is it the only polyclinic in London? Certainly, it is designed especially for the Olympic Games.
Yeah, we had the polyclinic for there was one in each village, so we had 3 villages. So the one at Stratford, the biggest village, had the vast majority of the athletes, so that had all the services on site and was billed as a healthcare facility. So it was actually an NHS-owned building. So in Legacy, it's going to be providing healthcare for what's a new community that's going to be in the extended Olympic Village when that grows. I mean, we've left behind a new academy. There's a new school start opening later this year, and there's going to be a new healthcare facility, which is also going to be a community centre. And actually, if you look at the legacy of the polyclinic as a building, I think there are lessons that are mirrorable in everything we've been talking about, because it's going to be a building that has community dental services in it, community health services in it, primary care, probably some physiotherapy. There's probably going to be some sport medicines, outreach clinics from hospitals, but also probably a gym, probably some community care, some community services. So all actually in the one building. And if they can capture this notion that actually they're not this bit and this bit and this bit, but they are just the building.
I mean, in a recession, we're obviously not likely to have many rebuilds elsewhere, certainly in the short term. Yeah. Is there anything that can be transferred in terms of people working together as a system that could be used elsewhere, even though they might not have the luxury, or unlikely to have the luxury, of a polyclinic building?
Yeah, well, the building's just a place to do it. It's what you do that's important. And you can and probably should be doing it everywhere. This notion that you take people for their skill set, for their expertise, for what they bring to delivering healthcare, in its broadest sense, is where you should be looking. So rather than what has been slightly old-fashioned hierarchical doctors, nurses, I always hesitate to where do you put them when you talk about the hierarchy of doctors and nurses? When you have
nurses,
but just the distinction between the two groups. Of course, there are distinctions because they bring different skill sets. But the point is, neither of them brings an allied health professionals and social services and community services and charities. None of these people on their own bring all of the skill set, but together, actually, they become greater than the sum of their parts, to use a fairly overused expression. But I think it was true in the polyclinic, where the great advantage of having everybody in uniform, they all looked the same. When I look back on it, at the time I didn't really appreciate it, but looking back on it, actually having everybody in the same, everybody looked exactly the same. That's fantastic, because it just immediately obliterates so much of the cultural barriers between different parts of healthcare provision, and they just started to work together.
That sounds an extraordinary piece of learning. I mean, one thing I wanted to ask you all, it's about training and trainees. Now, there were no trainees with you as trainees. Some were there as experts in particular fields. I was just wondering how we can translate what you have learned, I mean, and there seems to be lots and lots of messages, into an environment where we will have trainees, because one of the obligations of all health services is to look after the quality and safety of care for today's and tomorrow's patients. So we have to train healthcare professionals and others. How do you think, and actually younger healthcare trainees are often possibly more hierarchical, because actually it's possibly safer in a hierarchy than being exposed. How do you think we can sort of bring them into such systems, and what are the implications, do you think, for training?
Sorry.
Laurence, you'll start.
No, because I was just thinking, if you think about how we train our junior doctors, and obviously we were involved with this, and there is a transfer of factual knowledge which has to be pitched at an appropriate level. So therefore you inevitably take your very juniors away as a group and your registrars and so on and so forth. But once you get past that point, we also, when we want to teach them how to care for a patient, how to examine, how to care for a patient, we still silo them into supposed levels of experience and ability. Now, simulation training, which is, is expanding, is starting to move away from that. But actually, of course, what we probably should be doing is exactly what David did so fantastically well with the field of play, is actually train them as a team. So the consultants and the juniors should actually be training on how to examine a patient, how to care for a patient together. They should be doing all of this. You shouldn't be siloing these training opportunities, but bringing them together and doing them as one single team. And everybody learns, and also learns not to fear each other, and that they can communicate with each other. And that old essence of the most junior person can see the mistake coming, but daren't tell the consultant. It's that cultural change. And I think that the way that the field of play and spectator teams were trained really emphasise how you can completely obliterate that culture and do something really powerful.
It's by going cross-disciplinary, and that needs to start from the formation. So we clearly see, still in medical schools, and I'm a physiotherapist as background, also in physiotherapy, you see it's too much a vertical stream. They should get familiarized with what is your partners in the medical services doing, so that they get a proper understanding on what is the role and the complementary value of the nurse, what's the relationship between a physio and a physician, these kind of things. When you build that in from your formation platforms from the beginning, and then you work that all the way through in all the trainings you do, and do more and more of these competency-based trainings rather than the factual knowledge, which you will need, but just use that knowledge in a team approach. Then you create 1 + 1 being 3, and that's ultimately what we want to achieve here.
Yeah, I agree with that.
Okay.
That's definitely what, when we talked about the role-specific training, we had 3 sessions. We had the polyclinic teams, we had the EMS team, emergency medical service team, and the sports team, and we threw them together in a room. Again, they didn't have labels, I'm a doctor, I'm a nurse, whatever, or physio, and they sat at the tables, and the noise and the bubble that came out of the room when they were getting to know each other was amazing. And that was the beginning of this level playing field, basically, and that part of that teamwork. And I've been working in and around the health service for probably as long as David, but a lot longer than Laurence. Starting off in nursing, very hierarchical, and gone through my life thinking, hang on, we all deliver something to the team. And that's what I set out to do. And I think as a team we did it, and we recognised it, and it is transferable.
And David, you obviously have great success with your field of play.
Yeah. So the field of play teams, I think it was something which we experimented with and worked with a little bit. What we did was we looked at people's skill base, and we used that skill base within the team. So on various days we had different people leading the teams, even though they may be the same, and we had paramedics leading teams of very, very senior field of play consultants who leading football team, field of play teams in normal life, were quite happy to be led by somebody who had a different skill base, and maybe sometimes even a better leader, and letting the individuals do their skills because they were better at it than rather worrying about team leadership at the time. So I think my message would be is don't look at people as being juniors or seniors or trainees, etc. I think you have to look at what they're actually saying they can do, and I think clinical governance days, for example, allows trainees, trainees should be encouraged to actually speak up and say how they would actually, or their experience, which can be vastly different, how that can develop the process and develop the service and improve the service, or how they could spot something early, and not just saying, well, you've only done 1 or 2 years, what do you know about it? Some people come in nowadays with a vast amount of experience, which they're going to add to that medical programme.
I mean, it seems to me it's sort of obvious, and this is not just for the NHS. I mean, this is an issue to do with international healthcare, as we've been hearing over the last 3 days. How do we accelerate this? I mean, it seems to me sort of it's from what you've said, and actually from other stuff we have heard over the last 2 or 3 days about team working, about the importance of patients participating, etc. How can we accelerate that? Because I can see us talking about this over the next 2, 3, 4 years. Then there'll be Rio, and it'll be the same again, and we will continue. For 8, 12 years. Have you any thoughts about how we can accelerate the learning that's gone on into healthcare in general? David?
I would just go on with my, I believe it or not, team building exercises, people laugh at them, but we did a number of team building exercises, which there was a little bit even down to simple clapping as groups, basically, and getting to, that actually helps a lot. It broke down a lot of the barriers, etc. I know that a lot of big commercial organisations do this. The NHS doesn't encourage team building, and I think if they went for team building exercises within teams, gave that team, dare I say it, an away day to actually work as a team, get to know each other socially, to talk to each other even, is a huge benefit, basically.
Okay. Pam, any ideas how we might accelerate this? I think, I've probably been in health service probably similar times, and
Yes.
actually,
Yeah, no, I agree.
I would share your frustration that about hierarchies.
For me, going to work in both the Commonwealth Games, well, the Commonwealth Games first, because that's what I did first, it was a revelation to be in an organisation that was relatively flat. I was 2 steps away from the chief executive, and I could go and talk to him. But we were a team, and when I had to make some difficult decisions about the way in which we managed our first aid services, I went to the chief executive and the board, and we all signed up to the idea. And that was the absolute key to the way LOCOG managed the games. We were a big team, and we all had the same premise, and it was not a top-down, it was we all were on the same page, and that is actually very important. And I think the other thing is that although you have to worry about health, the quality and safety, you do need to be slightly not risk-averse. You need to be able to say, right, this is a bit risky, but we think it's going to work, make sure it's okay, and go for it.
You're talking about organisational risk, aren't you, as opposed to patient safety? I mean, in a sense,
Yes,
it's a different sort of risk.
Yes, but I think it's that's very important. If you're all on the same page and you all have the same understanding as an organisation, that gives the okay for people to work in a safe and feel safe about taking this little bit of risk, working together, changing, making change. I think maybe people in the health service now just aren't given that responsibility, and I think that's the issue. We gave responsibility to our volunteers to use their skill and make decisions. We put the framework in, the organisation was happy with that, and then we went for it.
But because they're a team, actually a risk isn't actually the risk isn't down just the lightning rod isn't one individual, but it's actually shared across the team.
Up and down.
So the risk is sort of it's a much lower.
The risk.
Absolutely, it lowers it as though it is a risk,
Absolutely.
but it is actually lower. The impact of that going wrong is going to be minimal because you've shared it across a team.
Yes,
and
and accept that you won't get it right all of the time, but it's not because you're at fault. It's because as long as you can analyse it and go back and address it, and we do that a lot, and feel safe to do that and supported to do that, then that's also a hurdle to get over.
And that would enable us, because one of the things that Dave Brelford said, who was the coach of the British cycling, successful British cycling team, one of the things he said was it was the accumulation of many small improvements.
Yes,
It's not saying that the improvements happened linearly and took sort of 100 years, but actually the small improvements happen this way, in which case you make a great leap forward, which it struck me as being a really important bit of advice, and the success was extraordinary.
Yes, he came and talked to us a lot. As a whole organisation.
Okay, so you were coach. Okay,
He came and coached us as well. We were coached by him as well.
That was the other thing, because you were coached. Well, that is a really another bit of learning. We've heard something about coaching and mentoring, because there's a bit now, of course, in austerity, people put all of that in the that's too expensive box. But actually, it seems to me it's a false economy not to include these. Peter, anything you'd like to add?
You're all in the same box. That means the ultimate product to be delivered is, in this case, is the games.
Yeah.
And no single party has a single responsibility in that one. It's the collective effort. Yeah, and I think LOCOG did an absolutely great job by just ensuring on the senior management level also that there was that cross function of all these things, and just giving confidence to the people to deliver and be part of that common goal under an absolute great leadership. I think the leadership of SEPCO, athlete driven in that one, has been crucial in that regard. Now, having said, London has created a unique landscape. And that's what now is important, is that they take this information and they transfer that knowledge. There are formal pathways of transferring knowledge to future organisers, which they did, but initiatives like this one, where you reach out to the policymakers in the medical area across the board, there's so much lessons to learn from that one, and it's good to see that now also an organising committee like Rio, who's the next big deliverable in 2016, they're taking some of these London consultants on board now to already start building that momentum. That's the way it should go. It needs to be translated to each and every unique environment. There is national legislation that is causing some hiccups on occasion. There may be language skills that there is certainly cultural difference. Yeah, London was very policy driven, which is great, but it tends to put people in a box on one side. Rio does it in a different way, and they tend to make it happen on the last minute. That's where they have a learning on London. They are very well aware that it's not going to work like that one. But what is crucial in that extent on an international scene and in the sport environment is the season before the games. It's the test event season, which is just clusters of repetitions to go through, where you bring these teams together, where you build that capacity and build that momentum, and then ultimately 5, 6, 7 years of planning delivered in 60, 70 days of a big festival. So.
Laurence, anything you'd like to add to that? How are we going to...
I think what Pam and David said, so translating from the games into healthcare, everything, I agree with everything they said. I think that there is this thing about the NHS and trusts investing in it, and it has to be seen as an investment for the future, because it does require people to come out of the coalface in terms of time, and it also requires money, because good training, you don't just put people in a room, you have to facilitate it, you have to have a framework within which the training occurs as well as everything else. And the thing that worries me is that and dare I say it, the choice we often don't get people together as a team for long enough, and it's great because as the senior staff and as the allied health professionals and the nursing staff, they tend to stay together for some time, and you can build a real rapport and team along them. But then what you do every 3 or 4 months is drop a whole new load of junior doctors in, and then take them out and drop new ones, take them out and drop new ones. And I sometimes think, I sometimes regret the fact we don't get them for longer, and so that actually we can make them part of it. So you tend to end up with the team and them is very common. So we may need to go back and look again at how that happens, because they're still drifting from job to job and never actually feeling part of this process, even if you're trying to do it.
Can I just add something to it? Again, it's on an organisational level. During the planning of the Games, we had people like Dave Brailsworth came and talked to us, other athletes who talked about how they survived as a team and how they delivered and their services. And that was very good training for all of us, because we had a rower who came to talk to us about what made their rowing team win the gold medal. And it's that sort of taking a step back and looking at other ways. And that was just a monthly meeting. They would come and talk to us for an hour. And we would gather there in a room and they would talk at us for an hour. Eventually, as we got too big, obviously you couldn't do it. But in the initial stages when we were planning, that team building bit was very, very important. And we brought people in from outside to give us that talk. And maybe that's what the NHS need to do. Definitely look outside the box, because there are lots of lessons outside.
I think probably not the NHS. I mean, this ties in very well from a session I've just come from at the forum, where some doctors in training and others described the learning that they've done to get them involved in quality improvement in their trust. And actually the word team comes up, involving them in the work of the organisation. And actually, I mean, the implication for what they were saying actually fits in what you were saying, Laurence, but actually involving them and actually making them part of their organisations. I just want to thank you all very much indeed, and just really sort of give you warning. I think this cannot be the last time we're going to allow you to discuss this and to bring your learning to both London, NHS in the UK, but also, I think, importantly, the lessons here for healthcare and the quality of healthcare internationally. It absolutely resonates with the sessions that we've had here. And really, if team working was a drug, everybody would have it when they went in. We've somehow got to translate your experience into healthcare so that it becomes the norm in all countries. Thank you all very much indeed.
Thank you.
Thank you.
Thank you very much.